Welcome back to the House Health Committee, and welcome back to voting list number 9. It continues to be Thursday, March 19th, just a little later, and we're going to continue our voting session. We're going to start with House Bill 181. This is Public Health Restaurants Disclosure of Main Food Allergens. This is Kristen Hill. Now, for the awareness of everyone, this was a bill that was worked through subcommittee and was worked out, but we did not send it back to subcommittee. So Chris and Hill.
As originally drafted, the bill required a restaurant to offer a written disclosure of each main food allergen that a restaurant knows or reasonably should know is contained as an ingredient in each menu item. Disclosure must use the common names of the main food allergen or standardized pictograms. The bill does not apply to prepackaged foods that are subject to federal labeling requirements for main food allergens. A restaurant that violates the bill's requirement is subject to existing civil and criminal penalties.
Would you like to just jump to what it does now?
Oh, I actually abbreviated.
Oh, okay.
Amendment number 1 makes technical changes. Amendment number 2 amends the bill to only cover food service facilities, updates the bill to match federal law around major food allergens, streamlines provisions by requiring one written disclosure and notice for the full menu available through a sign, display board, or other written material, and exempts third-party delivery providers as well as to-go and delivery orders placed through an online portal, mobile device, or third-party platform.
Delegate Hill.
Yes, so this was worked over and over and over again, and by the time we finally got it worked out, and as you said, then chaos ensued, and then chaos calmed down, and we're bringing it because the restaurants and the sponsor worked out something they were both happy with, and so I move the amendments.
All right, they've been moved and seconded, and we want to open it up for discussion. Delegate Kipke.
Thank you, Madam Chair. I just want to say that I appreciate that this is a lot less onerous on restaurants. The ability to make a living in the restaurant industry in our state is harder than ever with rising costs, labor shortages, and all the associated challenges with running a restaurant. And this certainly went a long way to addressing my concerns about the bill. I'm still going to vote against it. I think it's unnecessary. But I just wanted to say I'm very grateful for the reasonableness of the subcommittee and working towards a compromise on the bill. Thank you.
Thank you. Delegate Martinez.
Thank you, Madam Chair. You know, we weren't able to, I guess, get this worked out in subcommittee, but I do appreciate the folks offline getting together. I had a question, I guess, for whoever can answer. Does this apply to all restaurants in Maryland, or is it only those that have a certain amount, or is this just any restaurant is going to have to change their menu to these requirements?
I believe the amendments. Well, I did not accept the amendment about 20 or more.
I have it ready if you need it.
No.
So it's every restaurant?
So instead of restaurant, it's now food service facility, and that is specifically a place where food or drink is prepared for sale or service on the premises or elsewhere, or an operation, any operation where food is served to or provided for the public with or without charge.
With or without charge?
Okay, so I'm going to be a no on this, and the reason is because I have a restaurant in my district that is well known. I actually have a photograph of the historic building. It's Franklin's. Mike Franklin doesn't call or text me about anything, but this bill in particular, because they change their menu weekly, seemed very burdensome for them. I love the bill sponsor. I think it's great intentions, but I don't know if this is something that I can support for small businesses in my district.
Is there any, Delegate Schilek.
Thank you. So does this going to be applied to then like a farmer's market? Because it says food service.
Food service facility does not include a location in a farmer's market,
Okay.
or at a public festival, or a cottage food business.
Okay, but how about the Senate Cafe?
It seems to be covered.
Okay.
Is there any further discussion on the amendments? Delegate Ross.
Because I wasn't confused about this until you just said with or without pay. So does the bill define small business or those facilities in particular? Or could it just be like your annual fish fry? Like, can it just be like anywhere, concession stands at games, church picnics? I mean, the food trucks? I mean, is it just, it almost sounds that it's anywhere at all that food is given for pay or not pay in a public space, which is much broader than how I interpreted it before. I'm hoping that my interpretation is just off. I just don't know.
Delegate Hill.
I'm going to just read, if you go to page 8 on your reprint packet, so that everyone can be clear. Line 32, beginning January 1, 2027, each food service facility that uses a menu or a menu board from which an on-site customer may make a selection.
Can you use your microphone?
I'm going to read it aloud so the public, everyone knows what it says. Beginning January 1st, 2027, each food service facility that uses a menu or a menu board from which an on-site customer may make a selection shall provide to the customer a written disclosure and notice that informs customers that menu items may contain one or more major food allergens, the menu and ingredients are subject to change, and a customer should inform a server or staff member if the customer has a food allergy. Then we go on to the next page. Food service facility may comply with subsection C of this section by including a written disclosure on the food service facility's menu or menu board, making a written disclosure and notice available in a digital format through a QR code or a food service facility's digital menu or website. Those are all ways to comply. So it's not printed on every menu. It can be on the board. And then it goes on to say, making a written disclosure and notice available in a digital format. Oh, I said that already. And making the written disclosure and notice available through a sign, display board, or any other written material. So it's not by each menu item. It's not every time the menu changes. It's the statement and the list. And there are lots of ways to comply with it. And I think that's why the restaurants finally said we can do this.
Thank you. Let me go to Delegate Hutchinson and then Delegate Gazzoni.
Well, I have been in communication with the Restaurant Association, and they're neutral. They're not supportive of the bill. And when I was home for one of our weekends that we were able to go home, I actually went to 5 of my restaurants in my district and talked to them specifically about this bill. And what I kept hearing every time, and one in particular said, even with this bill, there is no way I would ever be able to make a dish that has no allergens in it unless the person said to my server, because I have cross-contamination throughout my entire kitchen. You know, I have flour going one direction, I got spices going another direction, I got everything. But I can 100% guarantee that they will have an allergen-free dish if they just tell the server that they have it, and they will go in the back and make all new dishes. Everything would be separate. That's the only way they could ever guarantee this. So I was only expecting this bill to go as far as a QR code that said, here are the 9 allergens. If you have any of these, you need to notify your server. What I'm hearing from the amendments is, no, we're still going down the path of, if you have a menu item, you got to notify that it has potentially one of those allergens on it. And I just think from a public health standpoint, we're not actually doing the service that somebody could still go in and be contaminated because they're not requiring that, notifying the server.
May I?
Delegate Hill.
I'm going to restate. Reading from the amended bill. What the notice says is, 1, menu items may contain one or more major food allergens. 2, the menu and ingredients are subject to change. And 3, customers should inform a server or staff member if the customer has a food allergy. So rather than the person pulling out their card and remembering, which many people do, rather than us trusting the waiters to remember to say, oh, by the way, if you have any allergies, please let me know, which a lot of restaurants they do, but a lot of restaurants they don't. This basically says, if you got an allergy, you need to tell us. So it's telling the restaurants, make sure that you have a notice up in some form that tells people if you have an allergy, you need to let us know, and I think, which is exactly to your point.
Madam Chair, if I may, but that's still not what I think I heard Chris say in terms of the amendment. I'm hearing that each menu item needs to be identified,
No,
and that's
please read the
problematic
packet.
to
Look at the packet. Look at page 7 on the packet.
Delegate Hill, let's go to Christopher one more time to hear the amendments, because I think what I was also hearing is that this would give you the ability to make a decision about the restaurants that you want to go to, because it would, indicate you in advance if there are allergens, but I may be mishearing that. So go ahead, Christopher.
Delegates, if you don't mind, could you repeat the actual question?
We're trying to understand like the operational aspect of this, whether it's a QR code that says these are the allergens, notify your server, or if this is like menu item by menu item.
So to my understanding of the amendments is that it is one notice or disclosure. So you come into a facility and you want to eat, and you're handed this notice and disclosure to say some of our food may contain these allergens.
Delegate Gazzoni.
Thank you, Madam Chair. I'm going to follow up on something that Delegate Ross noted, because years ago, because it's been a while now, I worked at a high school concession stand multiple times, football games, basketball games, dance recitals, and I think we may have had like a hand with a magic marker written notice of what we had on any particular day, but this would be pretty hard for food, because this would fall under, based on what I've heard, a food service establishment.
Let me go to Delegate Morgan, followed by Delegate Alston.
Yeah, I just wanted to say that I remember the bill hearing, and that was a worthy goal, I think. But I'm not sure this bill, the way it's drafted, actually accomplishes the problem or solves the problem that we were originally trying to look at. It just looks onerous from the restaurant establishment or, your high school snack bar.
I'm going to continue the discussion. So let me go to Delegate Alston, and then we'll go back to Delegate Hill.
Yeah, I thought that we were doing something that was like for the major chains. I did not think it was for everyone. And so I just think it's going to be too much. That means my church, when we're doing a funeral, is now going to have to comply with this. Well, there's a menu on a lot of maybe at the wedding, there are menus on these things, I think.
Chris wants to make a clarification.
Okay.
Go over what food service facility doesn't include, and I had to go actually deeper in it because it isn't included, something isn't included in the bill. So food service facility doesn't include a kitchen in a private home where food is prepared at no charge for guests in the home, for guests as a social gathering, or for service to unemployed, homeless, or other disadvantaged populations. A food preparation or serving area where food is prepared or served only by excluded organizations. An excluded organization is a bona fide, nonprofit, fraternal, civic, war veterans, religious, or charitable organization or corporation that doesn't serve food to the public more often than 4 days per week, except that once a year an organization may serve food to the public for up to 30 consecutive days, and a volunteer fire company. Also, a food service facility is not a location in a farmer's market or a public festival or event where raw agricultural products are sold, or a cottage food business. So I think churches are exempted.
Thank you for the clarification. Delegate Hill.
Yeah, so I was listening to Delegate Gazzoni talk about, boards where you handwrite. And I guess what I imagine you could do on the whiteboard, the chalkboard that you write stuff on every day, at the bottom, you just have something that stays there permanently, and you takes up an inch at the bottom. Always it says, these foods items may contain one or more major food allergies. The menu ingredients are subject to change, and customers should inform a server or staff member if the customer has a food allergy. So that would be fixed on the board, and you would erase and write your menu every day. Once that's on, you're compliant, you're done. I guess that's how I understand it. I just remember how complex the bill was, and this seems so simple to me, and since these were, what Mr. Thompson offered, I guess I'm having a hard time. I'm hearing everybody, but I'm not seeing it as being as onerous as everyone seems to. It's just a sign. It's like wash your hands before servers must wash their hands before they return to the, leave the bathroom. That's just a sign.
Delegate Kipke.
I'd like to offer an amendment to the bill. I have the amendment prepared. The amendment says that this bill only applies to a restaurant that is owned by a person that owns at least 10 restaurants in the state, which is a compromise over what the Restaurant Association originally said. But I believe it's easy for group restaurants to handle provisions of this bill because they have the resources to do it. There's going to be so many little places around the state that will fail to comply with this, not out of bad intent, and then they're going to get fined, and I just, I have a problem with that. So I'd like to offer this amendment as a way to maybe remedy some of the concerns that people have, and I'd like to move the amendment.
We actually have already moved the previous amendments and seconded. So is there a motion to withdraw the previous motion?
I'll remove my amendments and offer them after.
Okay. Because what I want to do, because there is very clear confusion and an offer of continued work, and given the late hour, I'm going to hold this bill. We're going to reconsider it for subcommittee if there is time. But I also, I too am a big fan of the bill sponsor, but I also think that maybe there was the ability to better understand it and bring it back as a complete product. So we're going to hold it for now for reconsideration based on the time that we have. So I'm going to hold that. It's my hold, so it doesn't count against anybody else's hold. I'll second you. House Bill 196. This is public health baby food testing, definition of baby food. This is Lindsay Ann White Holland.
So on page 11 in your packet is a reprint of the bill as amended in the subcommittee. As amended, the bill defines baby food to include infant cereal, but not infant formula, for the purposes of baby food testing, labeling, and related reporting requirements, as well as the prohibition on the sale of baby food that contains specified toxic heavy metals. Do you want me to keep going?
It's been moved and seconded, okay. but go ahead and just for the sake of everyone, go ahead and just finish the amendments, and then we'll have the discussion.
The amendments define infant cereal, define certificate of analysis, add to the definition of proficient laboratory, changes reference to toxic heavy metal to toxic element, authorize a person to continue to sell, distribute, or offer for sale infant cereal that contains toxic elements that exceed limits established by the FDA that's manufactured before April 1st, 2028, so that they can sell off their inventory, requires toxic element testing information to be available to the public without having to provide a UPC number, a lot number, or proof of purchase, and require manufacturers to provide links to the test results on web pages describing their products, requires QR code information for infant cereal beginning January 1st, 2028, requires manufacturers to retain each certificate of analysis for baby food tested for at least 5 years beginning April 1st, 2028.
Thank you. Delegate White Holland.
The bill was unanimous in subcommittee. I move the amendments.
Second.
Yeah, all right, they've been moved and seconded. Any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Any further discussion on the bill as amended? Delegate Szeliga.
Just confirming that this is already federal law, right? Did the manufacturers come in okay with this?
Reference to heavy metal, or excuse me, the term is changed to toxic elements is the limits established by the US FDA.
Perfect, thank you.
Seeing no further discussion, we are on the bill as amended. All in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. This is favorable with amendments. Who does not want to be on this bill? All right. House Bill 624. This is Hospitals Clinical Staffing Committees and Plans Establishment Safe Staffing Act of 2026. This is Lindsay and Gazzoni.
Sorry, I'm just looking at who's not here for the purpose of the co-sponsors. So this is the Safe Staffing Act. The amendments that begin somewhere in your packet, page 17, alter requirements for the staffing committees and plans to remove the word clinical, adds to the staffing committee a registered nurse who is not an ER nurse and a nurse practitioner, requires the staffing committee to consider input from individuals with specific expertise in staffing classifications, removes the requirement that MHCC post reports on the main page of its website, so just somewhere on their website, and alters the requirement for posting staffing plans.
Delegate Gazzoni.
This came out of subcommittee with, on a party line vote. As I think everybody knows, we've had this bill before, and it's been passed by this committee and the House a couple years in a row. And it's a little bit relaxed from previous versions. Yes, please. Can we move the amendment?
All right, amendments have been moved and seconded. Is there further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, on the bill as amended. All right, it's been moved and seconded. Delegate Hutchinson.
Thank you, Madam Chair. I do have a question. I guess it's for council, and I need a clarification. If I look at the text of the bill, and I think it's on page 4, line 12, it says assign personnel to each patient care unit in accordance to the clinical staffing plan. Isn't a clinical staffing plan, that's the clinical staff. So what personnel would be assigned to each patient care unit? That just seemed confusing to me.
I'm sorry, Delegate, I'm not certain I understood your question, but I will note that the word clinical is struck there, so it's in accordance with the staffing plan.
I'm sorry, I didn't hear.
The word clinical is struck, so it's assigned personnel to each patient care unit in accordance with the staffing plan. So essentially, they have to come up with a staffing plan, and then they have to assign personnel in accordance with the plan that they came
I'm
up
sorry,
with.
so the amendment struck.
The amendment struck the word clinical.
The clinical plan.
They have to assign personnel in accordance with the staffing plan. Does that answer your question?
That answers the question. Okay. Thank you.
Delegate Kipke.
Thank you, Madam Chair. I'll reiterate that I'm very fond of the bill's sponsor. But similar to last year, my concerns about this bill are that any amount of time that staff is spending having committees and preparing this type of stuff is taking away from the actual patient care. And we know that there's staffing issues. So I think about that as being a problem. There's enormous pressure on the hospitals because of federal regulations to get staffed. And as a backdrop, state hospitals are exempted. And they're the worst offenders with the most dangerous population. I read in our budget, there's an amendment to our budget that there's 500 positions unfilled in our state hospitals. And in my opinion, if this were a solution to the staffing issues in our hospitals, that should be the focus of this bill. But I mean, I understand that the advocates for it feel differently, but we just disagree about that. And, you know, for those reasons, I'll be opposing the bill. Thank you.
Madam Chair. Vice Chair Collison.
Thank you, Madam Chair. And I love my colleague to my far right. But I would suggest, in many ways, but I would suggest that part of the reason, there are two things. One, part of the reason they're having staffing problems is because of the overwork of the staff that's currently there. And I would say my belief is that if you bring the people who are currently there, know what the working situation is, know what the demands of the job is, they're going to come up, they're going to help prepare a staffing plan schedule that will meet those needs better than someone who's not actually experiencing it. So it's kind of like when I think I heard you say the other day, this dynamic kind of scoring, that you could actually save time and energy of the current staff by allowing them to participate in their own planning. Thank you, Madam Chair.
Seeing no further discussion, we are on the bill as amended. Great. Oh, Delegate Szeliga.
Thank you. I just am very concerned to reiterate what Delegate Kipke said about the onerous. I understand where we're trying to go. You know, it was on the ER wait time work group. We know there's a problem, but after they passed this bill, I asked how many units. This is a staffing plan by shift, 3 shifts in a day on most units. Hopkins has 84 units. So times 3 times every day. So that's a lot of paperwork. And, you know, I think that time would, I mean, we're all concerned, but I think the hospitals are also concerned. And I just don't think this is the answer. So again, I'm also very fond of the sponsor, and I appreciate all the work that's been done on this, but, you know, I don't think this is going to solve the problem. Thank you.
Thank you. Delegate White-Holland.
Thank you, Madam Chair. And just to offer some additional insight and building off of Madam Vice Chair's comments, I would just like to reiterate here that this is work that our hospitals currently do. It's just that it's not published as directed in the bill, right? And so given also there were comments during the hearing by both the proponents and the opponents related to the Joint Commission that translates to accreditation. And so in receiving a letter from the American Nurses Association that also highlights this, I would say that while, Delegate, to your point, and do not see that this bill is the one and only solution, right? It is a tool, right? How we pass a series of bills that addresses and approaches these challenges that we face. It is a tool, and it is a strategy that will better address some of the staffing challenges that the state is experiencing. And do believe that this bill, in its new amended form, will better position our hospitals to meet the goals outlined by the Joint Commission, to make sure that they are in compliance. And there is nothing in this bill that would prohibit them from crafting staffing plans that are unique to their own hospitals, that are flexible, and what have you. And so I just wanted to reiterate that we see this as a tool. It is simply that to address the larger scope of challenges and recognize that there are very well other solutions that are out there too. And I think in combination with that, it will better position our state to put us back on top when it comes to addressing the ER wait time issue. But I just wanted to offer that for the context of this voting session. Thank you, Madam Chair.
Thank you. Delegate Hill.
Yeah, thank you, Madam Chair. I just wanted to say the reason I'd like this bill. I like this bill because hospitals, like other institutions, have a top-down mentality that can be counterproductive. So when I'm in the hospital, which is not very often these days, but when I'm in the hospital and I'm on the floors and the nursing staff or the support staff are complaining, slowing down their work because they don't want the patients to come up from the ER because they're overloaded. When I'm in the operating room and an hour before someone's supposed to come in, the head nurse calls in and says, can you stay an extra hour because we don't have the people we thought. Some of it they can't do anything about, and I think that's why the hospitals were initially concerned, is I think they feel like if we could have gotten the people, we would have had the people. But I think that sort of from the nothing about us without us attitude, that if you're not asking the people who are actually having the lived experience, then you don't know why they're not agreeing to come, why they're taking off. What are the other things? Is it a nursing shortage? Is it a nursing aid shortage? Is it a training thing that the people you have can't do the jobs you need them to do? Is it, what support you need? And I'm sorry, you don't know. We deal with this all the time. People always think they know what the job is until they have the job. And so to have the people you're trying to staff participate in the conversation, I think is really important to solving the problem. And I would note it doesn't matter whether you have 5, units or it doesn't say there's a person from every unit. It says a dietary worker, not based on how many cafeterias you have, a patient care technician. It doesn't matter how many units, other non-licensed staff assistants. So I just don't think, it's onerous or over and above what they already do. The difference is that they no longer can just say, well, we'll pick our head nurse and our head surgeon and the anesthesiologist, and we'll dictate what we think needs to be gone.
Thank you very much. Delegate Kaufman.
Very briefly, but I think this is important. As an individual with cerebral palsy, I've spent more times in the hospital than I care to admit, and 15 surgeries and 13 hours on a gurney and very, very inattentive nurses in many cases. And because they're overwhelmed, they have 5 or 6 patients. So you hear from the hospital establishment that, oh, this isn't necessary because we're already doing all these great things. Well, respectfully, I don't believe it's working. So I'm excited to vote for this bill because I think a new approach is needed. Thanks.
Thank you. We are on the bill as amended. I will just say to Delegate Hill's point, I can't forget that we had to pass a bill to give nurses the authority to ask them to turn on a machine to absorb surgical smoke. So I think maybe this will help give the folks that are doing the work a seat at the table. And with that, all those in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. I've got Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. And this is favorable with amendments. Who does not want to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Thank you very much. All right, House Bill 637. This is public health recommendations for immunization, screenings, and prevention services. Oh my gosh, this is hard to read. Pharmacists, admin, and required health insurance coverage, the VAX Act. Lisa and Cullison.
This administration bill requires the Secretary of Health to issue, publish, and distribute specified recommendations for immunizations, screenings, and preventive services. It authorizes pharmacists to administer a vaccination recommended by the Secretary to an individual who is at least 7 years old and alters health insurance coverage requirements for certain immunizations, screenings, and preventive services, and repeals obsolete language regarding the pertussis vaccine. The amendments that were distributed from, that are in the name of the committee and passed by the subcommittee, they require the Secretary to hold a notice and comment period, obtain a specified analysis from the Maryland Healthcare Commission, and cite the authoritative medical organizations before adopting a recommendation for preventive services, and extend the time period for requiring insurance coverage after the Secretary makes a recommendation.
Vice Chair Cullison.
Thank you, Madam Chair. So we first took the amendments that were offered that Lisa just spoke to, and those amendments passed unanimously. So I'm going to move those amendments on this bill.
They've been moved and seconded. They've been moved and seconded. Any further discussions on the amendments as were passed from subcommittee? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right. Oh, Oh, is this on the current amendments? Okay, gotcha. All right, Vice Chair Collison.
So I just want to be clear about what the bill does, because there may be some confusion around whether or not these are mandates, whether we're changing, making really significant changes in our vaccination protocols. So when we talked about this in the last session, the General Assembly, said that we were going to honor vaccination protocols that were in place as of December 31st, 2024. And we did that because we anticipated a lot of irregularity and unpredictability at the federal level. We had been relying on a group of people in CDC to give us guidance around this, but the people who have been appointed in this new administration have a very different view of vaccinations. And so there was a fear that a lot of that was going to change, and we're actually seeing some of that because the number of cases of measles in this country have gone up significantly since that there's been this kind of new view of vaccinations. But what we didn't do is say, things change, things evolve. There may be new vaccinations. There may be new preventive services that we need to talk about. We may have a catastrophe. We may have an epidemic or a pandemic. And we've got to be prepared for those things too. So in order to be flexible enough to respond to emergency and changes, what this bill does is put the power of analyzing information about what's happening currently in this particular sphere of healthcare in the hands of our health secretary. And you'll remember, I think it was in 25 or maybe 24 when we said that the Secretary of Health had to be a healthcare practitioner, someone who has a background and experience in healthcare. So we said, this is a person we have trusted with healthcare in our state, and so now we're going to trust that person with looking at all of the evidence-based and scientifically proven results around new vaccinations and make recommendations based for immunizations in that, based on those studies. Primary sources for the Secretary would be the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists. So again, highly skilled and scientifically based organizations that are looking out for the health of our communities. We rely on these, we hear from these organizations all the time in this committee. So we trust what they say to us. And so now we're saying the Secretary of Health will use their information to make recommendations on what vaccination protocols should apply in Maryland. I want to be clear, though, it does not create any new mandates for individuals to be immunized. It simply is giving us a flexible and agile way to make sure that our vaccination protocols are updated in a cogent and scientific way. There is, with respect to preventive services, those are things like colonoscopies and mammograms. And we hear about new things coming along that maybe, we're going to use at some point or we're going to talk about. Those, anytime there's a consideration of those kinds of programs, there would be a public comment period. So the Secretary of Health wouldn't just be basing that on I'm going to say her because it's the current, on their current person, but rather information from the public as well as from these and other organizations. So with that, I guess I would ask if there are questions. Is that all right, Madam Chair, before we actually move the bill as amended?
Delegate Morgan.
Delegate Kipke was first.
Delegate Kipke.
I don't have questions. I have statements. I don't know if you want to do questions first, or you just want me to go?
I would say
Okay. So first, I have an amendment to the bill. The amendment would, just lost it, say that the secretary may issue recommendations for vaccines only if the vaccine was recommended by the U.S. Centers for Disease Control and Prevention Authority Committee on Immunization Practices on December 31st, 2024. It would limit the recommendations made to vaccines that were on the recommended list at that time, which is the pre-Trump era, which I know you all are dreaming about right now. And the reason I think that is important is, yes, we did change the law that the health secretary be more from some sphere of health, but they could have a public health degree. They can be a lawyer that practices malpractice insurance. They can just have some kind of policy experience related to healthcare. They could run a nursing home. So it doesn't mean that they're a licensed, trained medical professional. And it's my concern, as we've seen over the years, people have brought mandate bills to this General Assembly to require vaccination that we have rejected. And I think because we're in a little bit different position as somebody who is ingrained in a certain public health situation, I think they might be more inclined to support additional recommendations that may not be necessary for the public. And I think the process that we've had for the 2 decades that I've been here have worked and served the public better than just allowing some person with a public health degree to make these recommendations without a full public hearing where all sides can be heard and have a full public vetting, public votes, and the process that we have in our legislature. I'd like to move the amendment.
It's been moved and seconded. Vice Chair Cullison and then Delegate Morgan.
Thank you, Delegate. Thank you for warning us. I would ask the body to resist this amendment. While the person who is sitting as our Secretary of Health may be a public health professional at times, but that person would have always had a background in health. I have not. And as far as I know, the only person here who has any background in health is Delegate Hill. And so for me to say that I have the ability to make these kinds of decisions is worrisome to me, because I rely on the experts to tell me whether or not something is necessary. And in this case, these are so important. And in terms of making sure that our communities are healthy. Vaccinations are so important. I don't think that we should be putting it into in the hands of folks who are listening to different sides, but don't understand necessarily the biologics of immunizations, or we would be hearing opinions, basically. We'd be listening to scientists, and, we can hear that there are scientists on all sides, right? But as I've said before, we want to be able to make quick decisions. If we're going to rely on the legislature, there's nothing quick about us except during these 90 days. And so if we had another pandemic, how would we respond to it? And I'll remind you, we didn't come in for a special session to say that we could have the COVID vaccine. And whatever you think about the COVID vaccine, there are those of us who believe we're probably alive today because of it. And so I think, this wouldn't enable us to be as agile as we need to be. So that's why I feel like we can trust our Secretary of Health, and that person is going to use the best scientifically based, evidence-based knowledge in the country in order to make recommendations. Thank you, Madam Chair.
Delegate Morgan.
Thank you, Madam Chair. So let me understand this. Without Delegate Kipke's amendment pushed forward, the health secretary for the state of Maryland could adopt the next vaccine, maybe it's COVID-20, and implement that. And because he made that decision, it would be not mandated on everyone, but it would be recommended, and insurance would have to pick it up for free. It would be cost sharing at no cost, no copay, because of the legislation. Isn't that so? Because the cost sharing shift in this, I believe. There's no copay.
Keep looking to see if I'm right or wrong, is that if we were to recommend it, if it were to become part of Maryland's protocol and people chose to do it, then it would be at no cost share, because it would be considered a preventive service, a preventive, product.
We know how this stuff works, and I would just say that over the last, really, over the last 4 or 5 years, we've had a great many instances. As I remember, it was a time where nobody was allowed to question the COVID vaccine. That was the latest one that they pushed on everybody. And I remember taking a COVID vaccine that I didn't really want to take. It was mandated to me. I don't think I paid a copay for it, but I took it. And then it was pulled off the market about a month later. And that was the J&J shot.
Mm-hmm. Yeah.
So look, I know that many people on here don't like the Trump administration and them questioning things, but I honestly think that it's good in society to question the science. I think the science develops faster because people are questioning it. And look, people can make their own decisions, but to turn over the power of recommending.
It's late. It's 5.
It is late. I am done with this session. Over to just the authority of one person seems a bit reckless.
I will just speak a little bit to the recommendations are in consultation with a number of organizations. It made in accordance with the applicable recommendations of, if you want to look at page 25 of your reprint, the American Academy of Pediatrics, the American College of Obstetrics and Gynecologists, the American Academy of Family Physicians take into consideration the applicable guidance of the Maryland Statewide Advisory Commission on Immunizations, the U.S. Department of Health and Human Services, including the Health Resources and Services Administration, the U.S. Centers for Disease Control and Prevention, including the Advisory Committee on Immunization Practices, the U.S. Food and Drug Administration, including the Vaccines and Related Biological Products Advisory Committee, and the U.S. Preventive Services Task Force. And so it is in consultation. It's a little more prescriptive. It's broadening our ability to consider, scientific research and organizations. And I also will just say, and I greatly appreciate the sponsor of the amendment that we're considering, and the thoughtfulness to it. But I'm also concerned about the fact that, like, the flu season is October to April. It's not when we're in session. And every year we have a different flu vaccine that we have to consider. And it's a mix of science and some, like, just trying to understand the trends. But if we had to have a special session to adopt the flu vaccine, we'd actually be sort of behind the 8 ball. School starts in September. So I think we need the ability to be a little more nimble for preventive vaccines that do change every year. They are preventive in nature, and so we have some understanding, some anticipation of them coming on the market, but we don't necessarily know what the formulary is going to be year over year. And if we sort of bind ourselves to the recommendations of December 31st, 2024, which we did sort of in an emergency, like we didn't know what was gonna, we couldn't predict the future. This gives us the ability to be a little more nimble in adopting all of the science, whether we feel secure about what's coming out of the federal government or not. It allows us to have a broader consideration as we make these recommendations, as our health secretary makes the recommendations. So for that reason, I would ask the body to resist the amendment. All right. Is there any further discussion on this amendment? It's been moved and seconded. All in favor say aye. Aye. All opposed, go ahead and raise your hand on the amendment. So we have Delegate Lopez, Delegate Hill, Delegate Gazzoni, Delegate Warman, Delegate Kaufman, Delegate Rosenberg, Vice Chair Cullison, Delegate Bagnall, Delegate Taveras, Delegate White Holland, Delegate Martinez, and Delegate Ross. So the amendment fails. Vice Chair Cullison.
Sorry. Thank you, Madam Chair. May I move the bill as amended with the first set of amendments?
All right, it's been moved and seconded. Is there any further discussion on the bill as amended? Delegate Kipke.
Thank you, Madam Chairwoman. Respectfully, I just want to say I feel as though this bill is a major overreaction. I personally believe that vaccinations are one of the greatest inventions in the last 100 years and have saved more lives than potentially many other things, prevented more diseases, and, we vaccinate. So as someone with that perspective, let me tell you why I think this bill's an overreaction to what's happened in D.C. To put it on the record, the Trump administration lowered the recommended number of vaccines from 17 to 11. Remaining on the recommended list is diphtheria, tetanus, pertussis, polio. It was mentioned earlier that measles is going through the roof. Good thing that that's still on the recommended list. Mumps, rubella, varicella, I hate this word, pneumococcal, Hib, and COVID-19 remains on the list. None were absolutely removed. They were added to a recommended talk to your doctor list, talk to your pediatrician list. And those are flu, rotavirus, hepatitis A, hepatitis B, meningitis, and RSV. Many of those that are on the recommended list mirror what Europe does. And if you compare the rates of illness to places that mirror that policy, America does not have a substantially different rate of contraction for those illnesses. And so, I understand that the sky's falling and, the vaccine policy is dramatic. Some people feel that way. But there are others that feel that this might be a responsible approach. And that's not wrong to have that opinion. We can respectfully disagree. And so for those reasons, I will be voting against the bill. But I wanted to put on the record what is reality, as it relates to what is recommended and what is recommended that is discussed between a parent or guardian and the child's provider, their pediatrician. Thank you.
Thank you. Is there any further discussion? Delegate Hill.
Thank you, Madam Chair. I just wanted to put out, I think Delegate Kipke, you're absolutely right. A lot of this is ideological, but I don't think it's ideological with, and we're all entitled to our opinions. I don't think it's ideological about what the decisions are. I think it's ideological about what the process is by which the decisions were reached. So that my personal anxiety is that there was a deliberate decision to get rid of, and I know there's folks who think the elites have gone too far and education is not what it should be, and we should, lean into people we've known personally and have good locker room relationships with because they'll make better decisions. I get that. That's a choice. But I think when we're talking about health, historically, we have found that when we lean into science, we tend to have better long-term outcomes. So it really is the process that says that the science doesn't matter anymore, that minority voices should be given equal standing with the overwhelming majority of voices. That is what gives me pause, not the initial decisions. And I just want to make that clear. Thank you.
Delegate Alston.
Thank you. I just have a question. So this passes, will it change the required vaccinations for children that are going to elementary school and high school?
Not currently, but if something new is coming out, there will be, consideration of whether or not it should be included in the list, but that's prospective. It could change them.
So the recommendations that the secretary would make would then become requirements? Or is it like these are recommended vaccines, but they're not required for you to do them?
Right.
Okay.
Delegate Morgan.
Well, to piggyback on that question, it would become not a requirement, but a recommendation and be given at no cost.
Right, that's the point.
No
It's
cap.
recommended just like
Yeah.
at the federal level.
I just feel like it's exchanging one tyrant for another. Now we're empowering the state to kind of go at it alone instead of the federal government, what we had and what we're complaining about here. And I'm trying to figure out, I'm trying to figure out how in the world, if you read the legislation, how in the world does the doctor-patient relationship get any closer when you're allowing a 7-year-old to get vaccinated by a pharmacist, which is what's happening.
Happened for a while now.
So, well, I mean, we were just talking about, we want people to get a recommendation. Now they're getting a recommendation from their pharmacist and not their doctor, which is what we've done for years until we used COVID as a reason to expand this to pharmacists. So, yeah, I don't think we're going in the right direction. I think we're looking for a problem here.
Thank you, Delegate Morgan. Delegate White Holland.
Thank you, Madam Chair. And as a trained public health professional who has studied epidemiology, biostatistics, environmental health, and the gamut when it comes to the foundational aspects of public health, I would be remiss in offering just a few comments here. I think and Delegate Kipke, I also understand your thoughts here and how your reflection of this bill. I would say, though, what has raised concerns for my field in particular is how there has been an erosion of trust when it comes to the medical establishment, when it comes to settled science and the evidence that shows the effectiveness and how efficacious vaccines and immunizations are, right? I'm pleased to have gone to an institution where we would have heard professors and those that were affiliated with Hopkins that have had the experience in seeing infectious disease eradicated around the globe. And so now we're at a place where we're seeing high rates of diseases that did not have the type of outbreaks that we're seeing now that are starting to make a resurgence. And so I don't believe that with these recommendations and with the bill that is put forth that it will diminish or prohibit any person from still consulting with their physician. That has always been the case, regardless of which ACIP looks like at the federal level and what it looks like before or after this administration, right? And I don't believe that there is anything in this bill that would preclude anyone from having the conversation between the patient and their provider. I think at the end of the day, what our field desires is to have a trusted voice that is rooted in the science and the evidence, and that is what is concerning our public health field right now. And so as someone who has studied this, who continues to live and breathe and work in the field in this particular space, I will be pleased to vote favorably for this bill. Thank you, Madam Chair.
Thank you, Delegate. Seeing no further questions, we are on the bill as amended. And I would be remiss if I did not uplift the fact that Operation Warp Speed was under the first Trump administration. And that's kind of why we're here, is because this was a really important initiative that then was conflated and confused. And I think we want to take some of the politics out of it and get back to the public health. So with that, all in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Kipke, Delegate Shalega, Delegate Morgan, Delegate Hutchinson, Delegate Riley. So I just want to make sure I've got that right. So we are now on House Bill 772. Sorry? Oh, I was thinking it was an administration bill, all right, yes, okay. Who does not want to be on this bill? Delegate Morgan, Delegate Shalega, Delegate Kipke, Delegate Hutchinson, Delegate Riley, and Delegate Alston. Thank you, Lisa, for pointing that out. House Bill 772, this is Work Group on Behavioral Health Rate Methodology Modernization Establishment. This is Lindsay and Gazzone.
As introduced, this bill establishes the Work Group on Behavioral Health Rate Methodology Modernization in MHCC to develop transparent, cost-based reimbursement methodologies for certified community behavioral health clinics and outpatient mental health centers. The bill outlines reporting requirements for the work group and specifies that it does not require an immediate rate increase, mandate an appropriation, or create a fiscal obligation in the absence of subsequent legislative or budgetary action. The amendments that start in page 33 in your packet, adopted in subcommittee, alter the membership duties and reporting dates for the work group, and then also incorporate and make changes to existing law. These are requiring MDH rather than the Behavioral Health Administration and Medical Care Programs Administration to conduct a rate-setting study required under existing law, requires MDH to review and implement recommendations and administer tools and oversee submissions to support the study, requires MHCC to assist MDH with the facilitation of the study, tasks BHA and the Medical Care Programs Administration to develop and implement a payment system implementing the findings of the study and consult with stakeholders in developing the system, alters dates for the rate-setting study completion, and alters requirements related to the submission of the report.
Delegate Gazzone.
This was unanimous in subcommittee.
Move the.
It wasn't? Oh, sorry, yes, I'm sorry. I don't have my notes in front of me. Yes, wonderful opposed because there's a work group to it. I would love to move the amendments. Yes, please.
Second.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand on the bill as amended. All right, it's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega. Delegate Morgan. All right. So we are now going to move to House. Oh, thank you. Thank you for keeping me honest. Who does not want to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, thank you, everyone. House Bill 945. This is Nursing Homes Complaints Notification and Consultation. This is Lisa Ann Lopez.
This bill requires the Maryland Department of Health, when investigating a nursing home complaint alleging actual harm or immediate jeopardy to a resident, to notify the local health department for the county in which the nursing home is located. To the extent practicable, MDH must consult and coordinate with the local health officer on the complaint investigation and response. The amendments require notice to the local health department within 24 hours of initiating an investigation rather than immediately. They clarify that consulting and coordinating with local health departments is required as permitted under federal law, and specify that the new provisions may not be construed to require local health departments to assist the department or otherwise assume the responsibilities of the department in nursing home investigations. The amendments also establish the Healthcare Quality Initiative to identify strategies to improve the quality of care in nursing homes and assisted living programs, and determine how the state can best use and share available data and expertise for purposes of analysis, monitoring, public transparency, and oversight of nursing homes and assisted living programs. The initiative will be carried out by a task force that is required to engage with stakeholders, collaborate with the Maryland Healthcare Commission, and hold specified meetings. There is a preliminary and final report due by the task force.
Delegate Lopez.
Thank you, Madam Chair. This passed with one vote in opposition because it now has a work group. And I would say this bill looks different going out as it came in, and that was very intentional because we saw it as a vehicle to address or make a commitment to address some issues that have come up in testimony, in hearings, exchanges that we've had here in the committee room that speak to the need to really come up with a regulatory framework around the care in nursing homes, and also the one-size-fits-all structure towards assisted living facilities and having a more modern approach that is patient-focused. And so that's what the amendments represent. I would love to move this bill as amended, or move the.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Is there further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, and Delegate Warman. Thank you. Thank you. And who does not want to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Warman. All right.
We'll never see that again.
I was like, mark it down. All right, 10:02. This is nursing facilities, involuntary discharge or transfer. This is Lindsay and Gazzoni.
This bill specifies that a resident of a nursing facility may not be involuntarily transferred or discharged to a location other than the location identified in a specified notice, such as a hotel, shelter, or other temporary housing, before the facility to which the resident is to be transferred has confirmed that the resident may be transferred to the facility and the facility is prepared to accept the resident. The bill also alters specified requirements for notices, new notices, and post-discharge plan of care. The amendments adopted in subcommittee begin on page 47 in your packet, which correct the name of Maryland Legal Aid, removes from the bill a requirement that the discharge or transfer form include references to the availability of Disability Rights Maryland to assist residents, establishes time requirements that apply to discharge or transfer of a resident when a new notice is provided, and requires only certain new notices to include a notice of the right to appeal the new notice. The Finance Committee adopted the same amendments 10-0 on the cross file.
Delegate Gazzoni.
It took a little bit, but we got to a place where everybody was good with the amendments, and it was unanimous in subcommittee, and I would like to move the amendments, please.
Second.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, on the bill as amended. All right, bill's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, that passes unanimously. Who does not want to be on the bill? All right, everyone's on that bill. We have one more bill. You all are doing amazing. And it's going to make our life tomorrow so much better. House Bill 1372. This is Public Health Office of Healthcare Quality Information and Maryland Department of Health Centralization Commission. This is Lindsay Ann Rosenberg.
This is an emergency bill establishing, as introduced, the Maryland Department of Health Centralization Commission to provide ongoing advice and recommendations to the General Assembly on how best to improve the relationship between MDH and the health occupations boards to achieve greater efficiency, transparency, and accountability. The bill also requires MHCC in collaboration with OHCQ to develop a process to receive specified inspection and quality metrics information and publish it on the Maryland Quality Reporting website for each applicable healthcare facility. The amendments that begin on page 30 in your packet, adopted in subcommittee, remove the requirement that the date of the next scheduled inspection of each facility be published on MHCC's website, renames the commission, alters the membership of the commission, requires the MGA members rather than the Secretary of Health to chair the commission, and requires DLS rather than MDH to staff the commission, alters the purposes and activities of the commission, requires boards to designate a representative to be available to work with the commission rather than designating a liaison, and requires boards to respond to requests from the commission within 10 business days rather than 10 days, authorize the commission rather than the Secretary of Health to add priorities to the commission, alters language relating to the duties of the commission, requires the health occupations boards to provide DO-IT with information related to compliance with cybersecurity requirements rather than requiring the Secretary of DO-IT to ensure that the boards are meeting the minimum cybersecurity requirements, and requires the first meeting of the commission to be on or before July 1st, 2026.
Delegate Rosenberg.
This is which bill? I don't believe it's here.
1372.
Okay, I'm sorry. You're skipping down in the.
It's been moved and seconded. Is there any further discussion? It was unanimous in subcommittee. Is there any further discussion on the bill, on the amendments? All right. All in favor of the amendment say aye. Anyone opposed say no. Raise your hand. On the bill as amended. All right, it's been moved and seconded. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, it passes unanimously. Who does not want to be on this bill? All right, Delegate Shalega. All right, thank you, everyone. This concludes our voting session.